Hello everyone, this is Shadi Reis from CVI 2023. I'm really privileged to be with Dr. Steven Yakubov to talk about an important topic related to lifelong management of TAVR. Dr. Yakubov, thanks for being with us.
Thanks, Shadi.
Yeah, welcome to CVI. So as you know, the indication for TAVR is becoming younger and younger.
Correct.
So planning is important.
Yes, I agree with you. And as we are in clinical practice, many of the patients are presenting at younger age, not only at age less than 65, but then they come in and say, I want TAVR, I don't want surgery. Mm-hmm. So we have to figure out ways to deliver TAVI to those patients safely.
Mm-hmm. Especially these TAVRs, durability is good so far, but definitely during a lifetime, the patient might require another one.
Correct. We don't know how long the valves are going to last. We do CT imaging when the patients come in to pick the valve, but also we do that to plan how we're going to do the procedure. So if they do need another valve, what valve will it be? Which one do we start with? How do we maintain coronary access easily for a lifetime? And how do we get a couple of valves out of those patients, especially to last 30 years.
Absolutely. So how do you plan that? Is there protocols or things we should keep in mind?
I think the CT planning is the most essential piece. Mm-hmm. Knowing which patients should have surgery first, which patients can have the ability based on their anatomy to have 2 valves or more implanted safely without covering the leaflets, still having access, or without covering the coronaries and still have access to the coronary arteries reasonably well. And then we need better technology. You know, we need valves that will not have us worry about this, or give us technology that we can get rid of the old leaflets if we need to. So technology will solve a lot of that.
Absolutely. So in terms of, you're mentioning an important point about accessing the coronaries.
Yes.
So how, is there some planning required for that?
Yes, I think that planning for the coronary access involves knowing where to place the first valve, what type of valve to use, and then things like commissure alignment are so essentially important. So the commissures of these valves aren't in the way of getting to the coronaries.
Yeah. So, and there's a way to overcome that, and especially in surgical valves.
Yes. So the surgeons always put the commissures at the right place. Now as TAVR operators, we have to do that all the time. And most of it is the TAVR technology. The good thing is that TAVR technology is very fast. It's iterating quite quickly. Yeah. So we're getting better valves to accomplish all of this stuff. So I think down the road we'll have greater solutions for patients who want to have TAVR first below the age of 65 and will still preserve coronary access.
But we cannot talk about long-term management of TAVR without talking about durability.
Correct.
So what durable valves and which one we pick for that?
So first of all, we don't have enough durability data. We're still accumulating that. The best durability data that we have is from the core valve cohort of patients, both from the randomized TAVI and high-risk patient populations. And you can see that the self-expanding supraannular valves, not only do they give you better hemodynamics, but it appears as that translates into better durability at 5 years. We have a long way to go yet, but that's our best durability data so far. When I say that, it has less structural valve deterioration, less bioprosthetic valve deterioration compared to surgery. Okay. So I think we could potentially have TAVR valves that do last longer than surgery.
That's good too.
Yeah.
Last thing about medical management after that. Is there any antiplatelet therapy that showed long-term durability or an outcome of patients compared to others?
It's a great question. The best knowledge base that we have so far, we treat every patient who receives a TAVR with single antiplatelet therapy. There's been no data that suggests that dual antiplatelet therapy is better, and we still can't show that anticoagulation improves the durability of the valves at all.
Okay, so single
antiplatelet therapy, whichever one you choose.
Just one.
Yes.
Sounds good. Well, thank you, Dr. Yakubov, for your input on the lifelong or long-term management of TAVR. Watch these videos and others on the CVI YouTube channel. This is Shadi Reis from Austin. Thank you so much.